So we focus the whole day around that, and throughout the day we will bring some key concepts to your attention. The first one, of course, relevant to the patient, putting the patient at the center of all this, that patients do not understand why they have a colonoscopy and then potentially a year, 2 years, 3 years later, they are diagnosed with colorectal cancer. That simply doesn't make sense to patients. It shouldn't happen. And we want to present to you ways in which that can be avoided. So I would like to acknowledge, first of all, the work of my co-founder of the GIEQs Foundation, Dr. Roland Valori, in pushing this field forward. He's really an expert in the field of post-colonoscopy colorectal cancer, and I'm delighted that he's going to give the first talk describing the scope of the problem. Roland.
Thank you very much. So what I'm going to do is just show you a few, slides of images from my own county, not all from my hospital, and these are quite contemporaneous, and I'm going to show you some near misses to start with. So this patient, you'll see there's a slightly depressed lesion sitting in the cecum. The patient was on rivaroxaban. The person doing the procedure decided not to take that, and the patient was booked for a colonoscopy a month later. And this was done on a Saturday, and if you see from the imager, the patient's situated on their left, which is not the best position to see the cecum. This endoscopist reported there is no polyp in the cecum. And it was only by chance that I discovered that this had happened. And of course, the patient's going to have a colonoscopy, and the person who did, and if we did, we would have a 3-year interval. But from my experience of post-colonoscopy colorectal cancer, I knew this man was at high risk for 2 reasons. One, biological, he'd had a cancer and lots of polyps, but also because I've been doing a lot of work and taken a long time to remove these polyps, and that can affect my attention. So I said, let's have another look in a year. And COVID happened, and he had his surveillance at 23 months, and he's got this hepatic flexure lesion, and I'm sure I missed that. I'll put my hand up, and I say I missed this lesion or a precursor lesion 23 months before. So even the best of us, I have a very high adenoma detection rate. I'm meticulous in what I do, and things happen to me like everyone else. So you're probably thinking, well, I'm not going to have my colonoscopy in Gloucestershire with all that going on. But if we have a look here at the distribution of post-colonoscopy colorectal cancer across England, about 130 odd providers, our post-colonoscopy colorectal cancer rate is right down here. We're in the top 10th centile. And you have to ask the question, well, what's happening in the rest of these hospitals if this is happening in Gloucestershire? So there is a problem. And I would estimate that we could probably get the rates down to 2 or 3% with best practice.
No, it's very similar to what we've just heard about Belgium. We have difficulty in terms of we don't have a colonoscopy register where any one source or one person knows what's going on.
And what is, therefore, Roland, your advice to, because you've just heard from 3 countries who are nowhere near the beautiful data that you've been able to present. Sure. What is your advice?
So I think very often there's more opportunity than people think, if you like. So, my understanding in Queensland, for example, is they have a single reporting system in Queensland. Correct me if I'm wrong.
Throughout Australia.
Yeah. Okay. So then you've got your colonoscopy database. You should have your cancer registry, and then I would say that those 2 systems should have. I would guess they'll have patient identifier information. You should be able to stitch the 2 to find the cases. In Canada, to be fair, in Ontario's been very on the front foot in this. Some great work come out of Ontario, and they actually report back the frequency of post-colonoscopy colorectal cancer in their report card to the colonoscopy services. So I think often there's more opportunity than people think. And I just finished, David, by saying if anybody out there thinks that this is not a problem in their area or their country or their practice, then, they just got their head in the sand. So this is undoubtedly a universal problem. It will be different with different healthcare systems, but we know there's masses of data. We know now that colonoscopy is imperfect, and we know that there's great variation, and that we can do something about this. And that's what today is all about: is what can we do to prevent this, what is often the catastrophe for the patient, not happening.
Thanks, Roland, very much.
So what's the evidence for water-assisted colonoscopy? Well, first of all, water immersion reduces loop formation. In this study, looking at successful intubation of the colonoscope through the sigmoid colon without loop formation, there was a significant improvement with water immersion colonoscopy. So 53.8% managed to get through the left colon without forming any loops, compared to 37.5% for standard colonoscopy. In this Cochrane database review of pain with water immersion colonoscopy, there was significantly less discomfort during water immersion. And I think also that they demonstrated there was a less need for sedation during water immersion as well. The other key thing here is water exchange. More than water immersion increases adenoma detection rate. And as I say, I think this is due to the fact that when you're using water exchange, you get a much clearer colon on withdrawal. And so there's meta-analysis of 17 randomized control trials showed an increased adenoma detection rate for water exchange over CO2 insufflation. So as John Anderson would say, what's not to like about water immersion and water exchange?